Hello, my name is Patricia Johnson and I'm the nurse educator in the cardiac ICU at St. Paul's Hospital Heart Center. Before this year's virtual Heart Center Nursing Education Day, I would like to present to you a brief overview of heart valve anatomy, physiology, and valvular disease. Understanding the effects of heart valve disease begins with understanding normal blood flow through the heart. Circulating blood flows into the right atrium, through the tricuspid valve into the right ventricle, and is pushed from the right ventricle through the pulmonic valve or pulmonary valve into the lungs to get oxygenated. Oxygenated blood then returns to the heart into the left atrium, through the mitral valve into the left ventricle, and from the left ventricle it is pushed through the aortic valve into the aorta and out to the rest of the body. The tricuspid and bicuspid mitral valves are known as the atrioventricular valves. These valves are connected by tendinous strands called the chordae tendineae to the papillary muscles located on the ventricle walls. When pressure in the atria increase and exceed pressure in the ventricles, these valves open passively while the papillary muscles are relaxed. Toward the end of diastole, the increasing pressures in the ventricle help these valves close, and when the ventricle contracts in systole, the papillary muscles also contract to hold these valves shut and continue blood forward. The pulmonary and aortic valves are known as semilunar valves, as they appear convex or half-moon shaped from below and are composed of fibrous connective tissue lined with endothelium. During systole, the valve cusps are thrust forward from areas of greater pressure in the ventricles to areas of lesser pressure in the pulmonary artery and aorta, and then passively close as pressures decrease. When it comes to heart valve disease, there are two common terms you may hear: stenosis and regurgitation. Valve stenosis occurs when there is a narrowing of a valve, which restricts blood flow and causes the chamber behind the valve to work progressively harder to push blood through. This is similar to a stiff door that doesn't open all the way. To get through, you might need to use a lot of extra force to push these doors open just enough so you can squeeze through. Valve regurgitation is when blood leaks backward through a valve, instead of following its usual direction. This is similar to a one-way door that normally opens in one direction, then locks shut so people who leave a building cannot get back in. Instead of locking shut, once you walk through, this door might swing back a bit or not close properly, allowing people to get back inside the building when they shouldn't be. Both regurgitation and stenosis can also occur together when a stenosed valve does not fully close. Stenosis and regurgitation lead to problems with forward blood flow through the heart. Therefore, the signs and symptoms that might be present in heart valve disease are generally related to a disruption of normal blood flow. A common assessment finding might be a variation in heart sounds such as a murmur. If we recall, normal heart sounds follow the S1, S2 pattern, or lub-dub, where the S1 sound corresponds to the tricuspid and mitral valves closing, while S2 corresponds to the pulmonary and aortic valves closing. Let's take a listen to a normal heart sound. If there is turbulent blood flow through any of the valves, such as might occur with stenosis or regurgitation, a murmur may be heard. Murmurs are often described as swooshing sounds. Murmurs will sound different depending on which valve is affected, to which degree, and the intensity may differ depending on the auscultation location. Murmurs found on routine exams can be investigated further to assess for heart valve disease. Let's take a listen to a more common murmur that might be associated with aortic stenosis. This is just one example of a murmur, and though nurses are generally not expected to diagnose murmurs, recognizing any abnormal heart sounds and communicating them to the healthcare team should be part of a thorough nursing cardiac assessment. Other symptoms of heart valve disease that might be found on assessment might include ECG changes related to ventricular hypertrophy, fatigue or decreased activity tolerance, shortness of breath, more commonly on exertion but could also be at rest, presyncope or syncope, fluid backup into the lungs or to the extremities, angina, or an irregular heart rate. Now we'll take a look at various conditions that can affect each valve. Left-sided valvular conditions are more common than right-sided valvular conditions because of the nature of the left side of the heart being the workforce of the body, which typically involves higher pressures. The most common cardiac valve dysfunction is aortic stenosis. Aortic stenosis can be caused by age-related degenerative calcification and rheumatic disease. Degenerative calcification occurs when calcium deposits build up over time on the valve leaflets, in a similar process to atherosclerosis buildup in the arteries. Risk factors for degenerative calcification include advanced age, smoking, hypertension, and diabetes. About 1% of the population is also born with a bicuspid aortic valve. Over time, turbulent blood flow through a bicuspid valve, which is usually a 3-leaflet structure, can cause the valve to become thickened and calcified. A thickened calcified valve leaves a narrowed opening that obstructs blood flow from the left ventricle, which then raises pressure in the ventricle. As this is usually a gradual process, the ventricle adapts to the chronic pressure overload by becoming hypertrophic. Other causes of aortic valve disease include congenital critical aortic stenosis that would require treatment soon after birth, annular dilation due to aortic aneurysm or dilated ventricle which can cause aortic regurgitation as the valve cusps no longer close properly, and long-standing hypertension. Left ventricular hypertrophy caused by aortic stenosis can lead to heart failure, dilated cardiomyopathy, and sudden cardiac death. In patients with aortic stenosis, vasodilators, such as nitrates, should be avoided because they can exacerbate an already decreased cardiac output. If the patient is volume overloaded, diuretics should be administered cautiously to avoid lowering intravascular volume too quickly and sharply reducing cardiac output. Due to the proximity of the valve to the AV node, calcification of the aortic valve can also lead to atrioventricular blocks or left bundle branch block. Mitral valve disease is most commonly secondary to rheumatic fever. Rheumatic fever is an inflammatory response from your immune system, usually after an untreated Streptococcus A infection, such as strep throat or scarlet fever. About 60% of people with rheumatic fever go on to develop rheumatic heart disease. Every part of the heart may be damaged by inflammation caused by rheumatic fever. The damage can cause valve stenosis, valve regurgitation, and/or damage to the heart muscle. Most commonly, rheumatic heart disease affects the mitral valve and may take several years after an episode of rheumatic fever for the valve damage to develop or symptoms to appear. Rheumatic fever is rare in developed countries, but one Canadian study showed that people living in certain indigenous communities have a higher risk of contracting rheumatic fever. There is also a higher risk for people who have immigrated from countries where rheumatic fever is more common. People who have had repeated strep infections are also at a higher risk of developing rheumatic heart disease. Other causes of mitral valve disease include mitral valve prolapse, where the valve leaflets bulge up into the left atrium due to the valves being abnormally stretchy or related to other health problems such as a connective tissue disorder, severe calcification over time, congenital abnormalities such as mitral stenosis or mitral atresia, where at birth the valve is closed or does not form at all, atrial myxomas or tumors, and papillary muscle or chordae tendineae rupture, a rare but serious complication of a myocardial infarction. Chronic volume overload is common with mitral regurgitation, leading to the need for fluid status assessments and potential diuresis to prevent backflow of fluid into the lungs. Stretching of the left atrial wall from left atrium pressure buildup can lead to palpitations and heart rhythm disturbances, particularly atrial fibrillation, which may then require atrial fibrillation management, including anticoagulation. When mitral regurgitation is acute, this is usually due to papillary muscle or chordae tendineae rupture following a myocardial infarction and would require emergency intervention. Though disease of the tricuspid or pulmonary valves is rare, there are disorders that can affect these valves, particularly congenital heart defects. Causes of tricuspid valve disease include tricuspid atresia and Ebstein's anomaly. Ebstein's anomaly is a condition in which the tricuspid valve is located lower than normal and has abnormal leaflets. This can cause regurgitation as well as the ventricle to be too small and the atrium too large. Tricuspid regurgitation has also been found post-heart transplant. This is thought to potentially occur due to certain techniques, though these are generally no longer used, pulmonary remodeling from previous left-sided failure, or, most likely, due to the need for frequent biopsies and potential irritation to the leaflets, chordae, or papillary muscle when the biopsies are done. Tricuspid regurgitation may also occur due to dilation of the valve ring, secondary to right ventricular dilation. The most common cause of pulmonary valve disease is congenital heart defects, such as pulmonary atresia or tetralogy of Fallot. Tetralogy of Fallot is a heart defect with 4 different problems: a hole between the lower chambers of the heart, the aorta lying over this hole in the lower chambers, overly thickened walls of the right lower heart chamber, and an obstruction in the pulmonary valve causing pulmonary valve stenosis or complete atresia. Both tetralogy of Fallot and pulmonary atresia on its own can occur, but are usually addressed shortly after birth. Long-standing pulmonary hypertension could also have potential effects on the pulmonary valve. Heart valve disease can also be caused by an infective endocarditis. Infective endocarditis is a disease process in which a bacterial infection of the lining of the heart can cause a buildup of debris or vegetation on the heart valve, causing damage to its leaflets. This can be caused from a blood-borne infection introduced by dental or invasive procedures such as surgery, cannulation, or intravenous drug use. Those with existing valve abnormalities, such as many we have already reviewed, are at a higher risk for developing endocarditis. Due to the higher risk of endocarditis, patients with existing valve disease or abnormalities are often recommended to be given antibiotics prior to invasive procedures to prevent systemic infection. Initial diagnosis of endocarditis usually involves blood cultures to be drawn prior to the start of antibiotics, as well as a transesophageal echo, which, despite requiring sedation, does provide better identification of vegetations as opposed to a transthoracic echo. Hopefully, this presentation has provided some background to our Heart-Centered Nursing Education Day, which will further explore the interventions, treatments, and outcomes of heart valve disease.